Okay, so today we are going to discuss about changes of visual functions with age, especially in optometry student. It's very important when it comes to exam. So I have made it in three parts. So basically, part one, part two, and part three. We're going to discuss about visual functions change and a little bit a very common disease with age. Basically, very common disease which is related to eye and how it changed the thing. And definitely we are not just going to discuss about the anatomical aspects. We are going to discuss about the functional aspects as a visual functions. Okay, it's very important. So let's move and let's discuss in part one and then slowly in part two and then slowly in part three. So basically, what is aging? It's basically a gradual, irreversible biological change that occurs over the course of time and that do not result from the disease or other accidents and eventually lead to the increased risk of death in near future. Basically, it's a biological change, irreversible change, gradual change in a course of time, isn't it? Aging, simple. So there might be other definitions, but I'm sorry. I have this one. As a person ages, anatomical and physiological uh, changes, physiology undergoes changes, yeah, and they become more apparent with the increasing age. Okay, so aging is a progressive physiological process characterized by degeneration of the tissues and organ system, and consequently loss of function in a reverse of the system. So basically, loss of functions. Okay, function. So, what are the loss of functions in visual functions? That's what important in perspective of optometry, isn't it? So similarly, aging results from anatomical and physiological changes in eye. Uh, the discussed previous presentation means the presentations that we have discussed earlier, that physiological change is an anatomical change is very inevitable process. The change results in alternation of vision functions. Basically, that physiological and anatomical change results in visual function, isn't it? So let me clear one thing: what is actually visual function and why, and why that matters. The term refer to organic organ function as a parameters of the organ eye functions such as visual acuity, color vision, contrast sensitivity, visual functions, visual field. Basically, these are functions, isn't it? Can be generally measured as a psychological with a fair accuracy for each eye separately. It also describes eye and basic form visual function system function, and that's different. What is visual function and what is functional vision? These terms is, I think it's important. So basically, visual functions means to describe how visual system function, and we take this very important, isn't it? Even color vision, contrast sensitivity, visual function, visual acuity. These are very important perspective as a visual function for each eye separately tested. But functional vision means how the person functions in a vision related activity. That's functional vision. So, example, reading, driving, mobility, daily living tasks, and for a person as a whole. So, basically means driving, visual acuity, color test, field, which all visual functions actually gives the obviously there is use of food and everything, yes, but yes, this all visual acuity, color vision, field, people must have good field of view, and eventually it drives to driving ability, isn't it? So the many elderly people experience a visual problem that interferes with the daily living activity. So this topic is very important in geriatric optometry and even low vision, isn't it? So this so decreased visual function is a combination of mainly aging changes in neuronal elements of the visual system, changes in ocular media, and pupillary miosis. These all things are important, isn't it? Neuronal changes means changes in the retina, isn't it? So ocular media means cataract or the cornea or maybe vitreous, and pupillus with S, pupillus biased, isn't it? So ocular disease, vision loss are more prevalent than older population, and the four of the leading cause of visual impairment are these, isn't it? Macular degeneration, cataract, glaucoma, and diabetic, and these four of the major causes are different with the countries and countries. So there are several reasons why certain aspect of the visual function deteriorates with the age. So these factors we divide it into optical versus neural factor. So optical versus what is optical versus neural factor? What is optical senses? It means vision ultimately depend upon the ability to optics of an eye, isn't it? I always told my student one thing is optics means the eye will function as a camera, isn't it? It must focus on the retina. That's optical component, and another component is from retina till visual cortex, isn't it? That's neuronal component because from retina, that light energy converted into electrical signal. So, to produce good quality of retinal image, age-related changes in optics of the eye can have major effect on the visual functions. And good vision requires good optics. Basically means if refractive index shifts, index myopia, isn't it? Refractive index shifts of corneal shape and corneal astigmatism. These all things come into the optical senses. So another point of optical senses is absorption. So it's very common, isn't it? In older person, it's very common. One of the major changes in increased amount of light absorbed by the ocular structure along the visual axis. What are the major ocular structure that absorb the light, especially shorter wavelength? Is definitely crystalline lens, isn't it? So cornea more or less doesn't change so much, but lens, yes, obviously. So blue light wavelength around this reduction in the transmission of light and loss of transparency is greatest in the crystalline lens, isn't it? But also occur lesser extent in cornea. As I have said, cornea vitreous there is lesser extent, not that greatly changed with age. But crystalline lens, yes, it's a major change there, which means the absorption, high absorption due to the yellowing of crystalline lens, due to the aging of the crystalline lens, isn't it? So because of aging of the crystalline lens, shorter wavelength is absorbed more than younger person, isn't it? So what it creates, so main consequences is increased absorption and decreased amount of light reaches in the retina. One thing, absorption. See, there are two things. One thing, absorption shorter wavelength is higher. Okay, absorption in a range of shorter wavelength is higher, but at the same time, absorption of overall white light is also getting higher, not just shorter wavelength, and that's why what it creates is decreased retinal illumination, isn't it? And we have already talked about retinal illumination is taking in a unit of true land, isn't it? So the increase in absorption is much greater for the shorter wavelength. Yes, definitely, but other wavelengths also absorbed. Overall reduction in retinal illumination. What happens overall reduction in retinal illumination? So you can see this graph in many books, isn't it? Transmission of visible light in ocular medias. So basically, one is aqueous, this line, another is lens, two, three is vitreous, four is optoretina. Okay, we don't care about retina, but we do care about other like cornea, aqueous, lens, and vitreous. So this is how is the transmission curve, isn't it? So if it is the transmission curve, then maximum transmission around here, around 400 500 to 800 something, and obviously infrared lights too. But if the absorption of the shorter wavelength is higher, then the shifting of absorption spectrum is also there, so it's very important. So one thing is with getting is its absorption getting higher, and what it does is reduction of retinal illumination. The second is scattering. Okay, so another major change in the optics of the eye is later life is increased intraocular light scattering because of majorly because of the what do you call it, that lens. Although increased scattering may not lead to the reduction of amount of light of retinal illumination, but what it does with scattering, it does cause image degradation due to loss of image contrast by introduction of veiling. Some veiling means to like veiling effect. Like, can you see this picture? This clear, but this reduction of contrast, isn't it? Picture is still clear, face is still seen, but it's like low contrast. So that's what scattering does always. Okay, so these are the things with the optical senses. And optical senses, yes, definitely optical sense, myopic change, shift, presbyopia, and hypermetropic change. These all things are also considered in optical senses. Let's discuss about neural senses. Neural senses means retinal pigment deficiency is vital for the integrity of rod and cones. We know it. Why? So there is increased pleomorphism in RP, decreased number of cells in posterior pole of the RP, decreased melanin content in RP, and increased lipofuscin content and decreased volume of cytoplasm. So, which eventually cause loss of rod and cones and decreased cone density and decreased cone photopigment density. So, structural changes in outer segment of photoreceptor is also seen with the ages. So, decrease in number of ganglion cell and the nerve fiber layer is also commonly seen with the older patients. So, eventually come to the function of visual functions. What are visual acuity? Let's talk about visual acuity. So measurement of threshold determining the two separate, especially I have already made more than 10 videos for visual acuity, and many studies show that acuity decrease with the age. It's very common that if someone is 70 years old and when you refract and then you find 6/9 vision, don't you think it's a very good vision for that age? You don't try to push to 6/6 or 6/5 if he's comfortable with 6/9 and you got the 6/9, isn't it? So as a clinician we think like that. So it's very important that you have to know that with the age, yes, slight decrease in vision is common. The large proportion of this acuity loss is due to the neuron deterioration and cell death of the visual pathway. It's very important to understand because if you do cataract surgery or anything, visual still kind of 6/9 something. So factors are basically what are the factors that decreases the vision in case of old. One is refractive changes. Age-related disease definitely. Decrease in retinal illumination, no matter what cataract or no matter what pupillary myiasis. Increased light scattering, aging neural elements. Okay, so these all factors commonly cause reduction in visual acuity. So that's very important. The factors. So refractive changes. Let's take about refractive changes one by one. So refractive changes in the normal eye, free from cataract and diabetic, refractive changes means hypermetropia at the rate little or more than 0.25 per decade after 40. Means after 40, 0.25 diopter hyperopia per decade increase. I don't know. This is a rough guide. Okay. Due to increase in axial thickness of lens and the flattening of interior surface. Okay. So spherical emmetropia, what happens there? So Harris found that the median refractive state increased from 0.18 to 1.1 from 45 to 75. That he found it. Okay. So the dispersion of the refractive state increased markedly with the age. That sometimes yes, in older we found that in older as the patient get older, hyperopia is a little bit common. So myopia, prevalence of myopia, 1.13 diopter is this and increase 15% up to 15% over the age of this. I don't know in myopia, but yes, a little bit. The factor decrease in depth and the volume of the anterior chamber and the nuclear sclerosis. Yes, nuclear sclerosis is a major thing if it come to myopia. Yes, definitely. So decrease in depth and volume of anterior chamber basically means the cornea and the lens, if they get closer it will cause myopia, isn't it? If they go separated a little bit farther it will cause hyperopia. That's basic um, uh, ophthalmic optics stuff. So hypermetropia prevalence, this hypermetropia up to this 1.13 diopter and 45 to 40 increase up to 48% in age. So basically in older age, yes, a little bit hyperopia is common. So why? Because increased refractive index of vitreous. I don't know if this happened or not, but yes, cortical cataract we can think. Nuclear cataract causes myopia. At the same time, cortical cataract causes hyperopia. That's a theory till now. Astigmatism. Okay. So against the rule, astigmatism increases in older patient, while with the rule, astigmatism decreases. So basically, we know it, isn't it? The first born against the rule, astigmatism, and then in young with the rule, astigmatism, and then old against the rule, astigmatism because of that lead tension stuff, isn't it? We have already discussed it. So Hayes found the between the age of 40 to 80, the average change in astigmatism was one diopter. Okay, fine. So against the realistic astigmatism, over the age over an on an average 0.5 in to 5 in every 10 years, every decade. It's a rough guide. So change in astigmatism with age could be result from corneal astigmatism, internal astigmatism, or both. Yes. So basically, we have already discussed, isn't it? Agencyral astigmatism in born with the rural astigmatism because of the litonus a lot of time, and agencyral astigmatism again in older patients. So cause this fluctuation is the upper tarsal plate begins to lose its rigidity in middle life or beyond, and horizontal meridian is allowed to steepen. So basically, think this cornea again assumed an approximately spherical shape and resulting in a small amount of agencyral astigmatism. Okay, this is fine, but yes, the upper tarsal plate being loose is more of a story that we tell. So basically, presbyopia is very simple thing, isn't it? Because of the lens sclerosis. So lens become more difficult to deform in increasing age due to the lenticular sclerosis and poor elasticity in lens capsule. So lenticular sclerosis is, I think, the best theory we have. So near point lengthening with age and amplitude accommodation decreases with the resulting of difficulty in near vision. So what is the accommodation, amplitude of accommodation from which we think presbyopia begins? I think it's around 4 point something or whatever. So generally onset of the thought when amplitude of accommodation is decreased 5 diopter or less. Yes, I have told you this. If we think that if person has 5 diopter or less accommodation, then presbyopia begins, and it generally happen at around the age of 40. So amplitude of accommodation decrease becomes zero in sixth decade, and that's a rough idea. We have already discussed about accommodation. You can watch this video. So, pathophysiology of presbyopia, change of elastic property of lens capsule and the crystalline lens. Sclerosis, this one is very good. Sclerosis or hardening of the lens substance, crystalline lens, and weakening of ciliary muscles. I think it's not that uh, compelling theory, but yes, there is this theory. So basically, this, and I'll definitely talk about other stuffs in part 2 and part 3. There are 3 parts, I have already told you. So I think these are the great reference. You can see I have taken all the things from this reference. Okay, I think that's it. Bis dann, tschüss.